Hi, I'm Dr. Bernardo Mendes. I am the co-director of the UCLA Health Aortic Center. I am a vascular surgeon specializing in aortic surgery. Not everyone with an aortic aneurysm is a good candidate for an endovascular repair. Choosing the right patient is just as important as doing the operation itself. The most important factor is the shape of the aorta and the location of the aneurysm. The most common type is called an infrarenal aneurysm. This is a bulge that forms below the kidney arteries. We need a healthy section of aorta to attach the stent graft to. We call this section the neck of the aneurysm. It should be just over half an inch of strong, normal aorta. If that section is too short or too irregular, the stent may not seal properly. This increases the chance of leaks later on, which are called endoleaks. We also need good arteries at the bottom of the repair. The iliac arteries, which leads to the legs, need to be in good shape so that the stent graft seals securely at both ends. Another key point is access. The device travels up through the arteries in the groin. We have to make sure those vessels are wide enough and not blocked by calcium or clots. If they are too small or too twisted, an endovascular approach may not be the safest choice. Aneurysms can also occur higher near the arteries that supply the kidneys, intestines, or liver. Repairs in this area are more complex. In these cases, we may use fenestrated or branched endografts. These have special openings, which we call fenestrations or branches, built into the graft to keep blood flowing to the organs. To safely use a graft of this kind, the arteries have to be of the right size and in the right position. Some patients also have extra kidney arteries. They are very common, about 1 in 4 people have them. But if they are large and cannot be included in the repair, part of the kidney could lose blood flow, and in these cases we might recommend a slightly different approach. Some patients are not good candidates for endovascular repair at all. Patients with connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, or Loeys-Dietz syndrome may not be good candidates. These disorders weaken the aortic tissue. With some exceptions, these patients may do better with an open surgical repair, which can be more durable in the long term. Young, healthy patients may also choose open surgery for the same reason. It can provide a permanent fix with little chance of needing another aortic procedure later on. About 75 to 80% of patients with aortic aneurysms are good candidates for endovascular repair using the devices exactly as they were designed. If we stretch the limits of what these devices are designed for just a little bit, almost 90% can be good candidates. Careful anatomical planning and patient selection are what make these minimally invasive repairs so safe, effective, and long-lasting. Our focus is matching the right treatment to each patient for the best possible outcome. I'm Dr. Bernardo Mendes with the UCLA Health Aortic Center. Thank you for listening.